Welcome to the first Hallmark Advanced Imaging Small Animal webinar series. There are 4 lectures that are going to take place over the next 7 weeks, and we're going to focus on current MRI and CT topics. We have 4 tremendous speakers for you in this inaugural series, which is sponsored by Hallmark. Links to find out more information on Hallmark will be provided on our Facebook site. And the recorded versions of these lectures will be hosted on the Hallmark YouTube site, as well as on our website, which is www.web-vetneurology.com. Kicking us off today, we are very excited to have Dr. Amanda Taylor, whom I've seen speak on several occasions, so I know that you are in for a treat as she addresses the approach to MRI interpretation using pattern recognition and some great case examples. So by way of introduction for Dr. Taylor, let's talk about origins and where she is now. She received a DVM from Texas A&M College of Veterinary Medicine and Biological Sciences. She completed an internship in small animal medicine and surgery at Colorado State University and a residency in neurology and neurosurgery at Texas A&M University. Dr. Taylor is certified in neurosurgery by the ACVM, acupuncture by the Chi Institute, and canine rehabilitation by the University of Tennessee. Her research interests include MRI and neurosurgery. She is currently a neurologist and neurosurgeon and the Director of Education and Wellness at Southeast Veterinary Neurology in Florida. Dr. Taylor is board certified by the American College of Veterinary Internal Medicine in Neurology. So perfectly positioned to give us this talk and share her experience today with us. So welcome, Dr. Taylor.
Thank you, Dr. Platt. Start sharing as soon as Rachel pulls this intro slide down. There we go. All right.
All right, I'm going to hand over to you and get out of the screen,
Thank
and
you.
I'll see you at the end. Thank you very much.
Thank you. There we go. So excited to be here today to talk to y'all about optimizing neurological MRI presentation interpretations. It is something that I'm rather passionate about, and having trained residents and students for quite some time have seen people struggle with this quite a bit, especially when they're used to being in an institution where everything is read by a radiologist, and then suddenly they're in a practice where there's not a radiologist who reads their scans. So hopefully you'll find this helpful as you approach MRI interpretations in the future. So one of the things that I think is key to learning in any environment, but particularly when you're learning a new concept, new skill, or new topic, is writing down the information to get a better grasp on it. When you write down information by hand, you actually engage a broader network of your brain. And you retain memory better than when you type your interpretation or even just dictate. You engage motor, sensory, and cognitive processing when you are handwriting. So when you're watching a lecture such as this, I recommend you write your notes, not type the notes. It'll slow you down and kind of force you to process the information that you're receiving. Just in case you don't believe me, this has actually been tested. Students that take notes by hand perform better and actually engage more cortical activity, as seen on EEG in these very lucky students in Norway who got to wear EEG caps while they either handwrote notes or typed them during lectures. And I've actually done some studies where they've looked at whether or not students score better on tests when they handwrite their notes as opposed to type them, what happens when they review those notes. And ultimately, handwritten notes result in higher achievements, even though it does take you longer to write those notes. So moving forward in this lecture, I hope you got a pad and a pen or pencil so that you can write down some tips. But also, as you move forward with your neurointerpretation of MRI, consider writing down your findings when you begin to formulate them moving forward. So, outcomes or goals of today: to learn advantages of pattern recognition and interpretation, To use a neurologist perspective to identify lesions and causes, because I do think it's a bit different than a radiologist, to know which images are best for which types of pathology, and ultimately to try to start a small or atomic habit of consistent image review. So first we'll talk about pattern recognition and how signalment and timeline progression and neuroanatomical localization, as well as non-neurologic signs play into that. We'll talk about normal on the individual magnet that you are probably dealing with in your practice, which clinical question we're trying to answer, disease prevalence, how to arrange your images, ultimately image review, and then conclusions. So I've based this talk around a book I read a couple of years ago called Atomic Habits, written by James Clear, which is really about making really small changes that you can stick with consistently in order to move forward to something that is momentous and change. And I think the best example I can think of is when someone goes on a diet. If you eliminate everything in your diet that you enjoy, you are unlikely to be successful. A diet of only celery juice is unlikely to last very long. But if you can find small changes to make, you're far more likely to be successful long term and have a bigger impact on your health in this example when it comes to diet, but maybe also in practice when interpreting MRI images. So in order to create a good habit, there are several kind of rules to follow. The first is that we should make it obvious that we should be doing this good habit in order to move forward. The second is to make it attractive, so it feels good to maintain that habit. The third is to make it easy to maintain. Again, drinking celery juice every single meal, probably not so easy. So how do we make it easy? And the fourth law is make it satisfying. There must be a reward to doing this habit every single day. And in this case, it would be hopefully getting a good answer to be able to move forward with in the case that you're reviewing on MRI. So pattern recognition is a great way to make it obvious. And whether you know it or not, you have been working on pattern recognition since you were a very, very, very young human, where you instantly perceive significance when you're presented with information. So just a couple simple examples here of shapes and colors that fall into patterns and what shapes and colors would be anticipated next. This really is ingrained in us as humans. And the first time I wrote this talk, when I started thinking about pattern recognition, my daughter at the time was in preschool. And these are the pictures that came home that week from preschool, where we were working on patterns and recognizing what came next in shape and color. So it starts from a very young age. And as you move through life, this is happening whether you know it or not. I'm going to kind of go through some pictures of some things maybe seen here in America or abroad, of things that you might recognize that are attractive to you. So this, if anyone recognizes it, is a logo for a company that may instantly make you think of a burger. This is Wendy's, which is in Ohio. It's based in Ohio, and some might call it a very good burger. Others of us prefer to recognize other patterns, such as this one, which is a different company called Whataburger, which was originally based out of Texas, and one might argue a far superior burger. And if you haven't seen some of these logos before, you won't recognize them. There won't be a pattern that is elicited. But if you have, such as this one, you might recognize that there's an excellent taco around the corner, because this is the logo for Torchy's Tacos, a really nice little taco chain that started in Texas as well. I live in a part of America where football is one of the things we celebrate more than many other things. And we're in the Southeastern Conference, the school that my husband works at. And there are some rivals for that school. And so it becomes very important and attractive to recognize that one of these A's represents that rival, the one on the left with the little kind of flip or mullet there at the back. And one of these A's actually just represents a nearby baseball team, the Atlanta Braves. So one of these A's we're super comfortable with where I live in Auburn, Alabama. The other one here on the left, not so much. And you might get booed if you put up the wrong A on occasion. Part of pattern recognition that is obvious to us as neurologists is signalment. when we look at a breed, we tend to think about certain diseases that they might be afflicted with that we're more likely to see. So, when seeing something like a boxer, if you're a cardiologist, first thing that might come to your mind is ARVC, arrhythmogenic right ventricular cardiomyopathy. But as a neurologist, I'm far more likely to think about diseases such as glioma affecting the brain or degenerative myelopathy affecting the spinal cord. Haven't seen very many Scottish Terriers lately, which is unfortunate because they are one of my favorite breeds. But most neurologists, when they see a Scottish Terrier, recognize that one of the conditions they're known for in our specialty is Scotty cramp, a condition affecting muscles in the back legs that can be managed medically. If you're not a neurologist, you may think of von Willebrand's disease, or you may think of something like transitional cell carcinoma, but you start to form recognitions of patterns based on the signalment, so that when you see a beautiful little red smooth coat dachshund such as this, you're very likely to think if this patient's coming to see me for difficulty walking, I'm probably dealing with intervertebral disc disease. Unfortunately, German Shepherds are afflicted by many conditions commonly that we see in neurology: degenerative myelopathy, idiopathic epilepsy. But in the general practice world, they're also known for other diseases such as GDV or hemangiosarcoma. And finally, the best of the worst or the worst of the best, depending on how you look at it. The popularity of this breed has been extremely high in the United States over the past 5 years, and we've come to recognize that there are certain neurologic diseases that they are more likely to get, such as glioma, meningoencephalitis of unknown etiology, intervertebral disc disease, and spinal arachnoid diverticula. In addition to looking at the signalment for pattern recognition, I recommend you think about the time and sign line of the condition that they are presenting with. Are we dealing with something that occurred acutely and got very bad very quickly, such as a trauma, a hit by car when an animal's unable to walk thereafter? Are we dealing with something more insidious that's taken some time to get worse, such as inflammatory disease? Or have the clinical signs waxed and waned, such as a metabolic or idiopathic condition? Make it easy when you're trying to form habits. Take this to MRI and reviewing it in the same order every single time that you do it, so that part of your review can become automatic and something you don't have to think about. It will prevent you from making mistakes. You can make it attractive by using habits that are going to make your review more likely to be correct and less likely to miss abnormalities. And that's going to feel good. You're going to feel satisfied when you interpret that MRI, and you'll have a sense of achievement, particularly when it comes to patient outcomes that are directed by good science and interpretation of the images. How can we do that? How can we make it easy and attractive? Well, control the controllable factors and interpretive error. There are some things you cannot control when you look at an MRI. Like if someone near you decides to suddenly start making loud noises, it might be a lot harder to interpret what you're seeing. But there are other things that you can prevent. There's errors in search where you don't see it when you look through the image. There's failure to recognize abnormalities when you do see them. You can make incorrect decisions about what you are seeing on the image. And you can lack attention or focus when looking at them. Cognitive bias, which can be positive and negative, in my opinion, when it comes to pattern recognition in neurology. Satisfaction of search, which means I found the thing that I think is the cause and I forget to look elsewhere, which I do see probably most often in neurology when people find an abnormality in the nervous system and forget to look outside it. And then prevalence effect. Again, this is positive and negative. We are more likely to find diseases that have high prevalence and less likely if they have low prevalence. So attention and perception. Here's an example from the human literature where a group of radiologists blinded to signalment were given a CT study of multiple patients and told that the purpose of the study was to identify nodules or abnormalities in the study consistent with metastasis. And in that study, nodules were readily recognized. You can see one here in the dorsal right lung lobe field. But what was missed 84% of the time by radiologists was this gorilla that they had hidden up in the image in the lower left lung field or anterior lung field of this human, which I really think is quite fascinating that many people missed it, trained radiologists. But if they can, we certainly can too. So it's important to look everywhere in the image and pay attention. As I talked about earlier, it is possible for us to have a satisfaction of search where we identify what we think is the lesion and forget to look elsewhere. And this is one such example. This is a case of T3L3 myelopathy who was found to have chronic disc disease, resulting in an intervertebral disc protrusion, as visualized here on the MRI. And unfortunately, the interpreter failed to recognize that little mass you started to see in the other image, which was an adrenal mass in this patient that was found to have cable involvement on ultrasound. So important not to forget to look outside the nervous system once you have identified a problem. Additional things you could do to make this easy and consistent. Ask yourself, does the lesion fit the neuroanatomical localization that you made? Most neurologists are very consistent and very good at their NAL when they perform exams, and that really should be trusted when they go to look at the MRI and identify lesions that do or do not fit with that neuroanatomical localization. We all realize there are some localizations that can trick us. Sometimes you'll have a case with profound neck pain that actually has a brain lesion, for example, or a case that you thought was lower motor neuron that in fact has an L4S3 lesion, as well as problems in the cranial region of the T3L3 spinal cord versus C6 to T2. When you're considering these cases, remember to consider, even if you're a neurologist and you're super focused on the best organ system in the world, are there any non-neurologic signs of disease? Fever, weight loss, changes on blood work or blood pressure, or if the same patient was imaged with another modality, are there any abnormalities there? Because it can cause you to consider other differentials for problems that you're seeing, such as infection or cancer, when we have these signs of disease. As you move forward in pattern recognition with your MRI interpretation, it's really important that you get familiar with what's normal by magnet strength, with obviously a better signal to noise ratio as we increase that magnet strength. There's 3 examples of cat heads imaged with 1.5, 3, and 7 Tesla moving from left to right. And you can appreciate how much greater that soft tissue detail is, that gray-white matter distinction, and how much less noise we have in these images as we increase signal strength. The same can be said with dogs. Fortunately, dogs do bigger heads and do have bigger brains, so there is more signal there to generate the image in the first place, but there are also distinct differences by magnet strength in how your image quality will appear. The same can be said of the spinal cord, where there is much greater soft tissue detail and distinction between soft tissues with greater magnet strengths, in addition to images that require fat saturation or stir images. I recommend you get familiar with your magnet. Even if you've grown up with a 1 Tesla or a half Tesla or a 0.35 Tesla, whatever it is, it's going to be very different institution to institution, in my experience, even with the same machine, because the algorithms between the institutions do not necessarily match. And this is an example of that phenomenon where you're looking at 3 different dogs, about the same size dog, all in a 1.5 Tesla magnet, T2 transverse TSE imaging. Look how different these are between institutions with the detail that's occurring and how clear the image is and signal to noise ratio and the appearance of the soft tissues and the distinction between gray and white matter. In addition to being familiar with what's normal for your magnet, you need to remember what's normal for the breed or normal. Where if you're looking at breeds, for example, that have known congenital differences in the structure that you're going to look at on MRI, you don't pursue it as something that's a problem and you recognize it as unique to that breed or those patients in that breed, such as an absent septum pellucidum and lateral cerebral ventriculomegaly seen in English bulldogs in imaging, which I've also found I see not uncommonly in boxers as well. And this is exhibited in the image on the left in comparison with a normal dog on the right or a non-English bulldog on the right. Not sure there really is a standard for normal for French bulldogs as far as their vertebral column structure. But in my experience, normal for this breed is to have multiple congenital abnormalities. We know based on the literature that this is highly, highly prevalent in the breed. Almost every French bulldog should and will have congenital vertebral abnormalities. And I think owners, when I see them sometimes after they've seen their primary vet and someone's taken radiographs of the spinal column, the clients are very quick to tell me, "Oh, look, this vertebra is abnormal, and this one's misshapen," and so on and so forth. And while it's very good that they've been educated as to how their dog appears on those radiographs, it's not necessarily the cause of the underlying reason that that patient is coming to see me. And while I won't dismiss it, I'm certainly not going to hunt this down first as the cause of an acutely non-ambulatory paraparetic French bulldog or in a vertebral disc disease and be a much more likely differential. In addition to remembering what's normal for breed, there are some significant species differences. And I'll focus mainly here on cats versus dogs, as they are the majority of the patients that I see, dogs and cats. But in normal cats, you see changes in the caudal aspect of the brain at the back end of the cerebellum, where there are three presentations that have been determined to be normal in cats, where you've got category C1 there on the left with this kind of really pretty, fluffy cerebellum. Got one with a flattened caudal aspect secondary to the occipital bone, which is here in the center as C2, and one where you not only have flattening of the caudal aspect of the cerebellum, but you actually see herniation through the foramen magnum. The caudal aspect of the cerebellum here is C3 as a normal finding in 40% of cats, with brachycephalic cats such as Persians being far more likely to display category C3. And if you did not know that about cats, you might consider that an acute change and have some concerns for increased intracranial pressure. This is just an example of a cat that was not included on this study, but one that I imaged at 7 Tesla who does have that C2 abnormality here as a normal finding or flattening of the caudal aspect of the cerebellum. In addition to knowing what normal tissue signal looks like on your magnet, it's important that you be familiar with what artifacts your magnet makes. I previously worked at a university that had a MRI that had been installed quite some time ago, and there were some issues with the shielding in the room that the MRI was in, resulting in a zipper artifact in nearly every MRI image that we created. It was extremely common for us to see, and that is identified by these vertical lines on this sagittal image and this horizontal line on this transverse image. Fortunately, this did not interfere with image interpretation in either of these cases, but is something that was often seen on this magnet in this particular room. And I found that very disruptive at first when I first came to work at that institution. But as I got used to it, it made it far easier for me to move past it and interpret my images. It's important to make it attractive to keep a habit. And to me, knowing what the clinical question is for the case you're looking at is how we make that particular part of the examination attractive. What is the cause of the dog's T3L3 myelopathy, for example? What's the underlying etiology of the multifocal intracranial signs? Or why is this cat painful in the lower lumbar region? And then when you are looking at your images, Does the lesion you are seeing answer the clinical question that you came into that case with? How often you're going to answer that question is going to depend on how often that disease is seen. Are we looking for diseases that are common? The more common they are, the higher probability you've got of an abnormal MRI. Remembering that if they're not very common, you might be less likely to find them. So in a dachshund with T3L3 myelopathy that's acute and painful, we're highly likely that we're going to have an abnormal MRI with an intervertebral disc herniation found. Disease prevalence, important to remember since they are one of our most common breeds seen, that the common causes of myelopathy signs in the French Bulldog are intervertebral disc disease or extrusion in most cases, with some affected by subarachnoid diverticulum. And those with intracranial signs, it's quite honestly a toss-up between intracranial neoplasia, usually glioma, and meningoencephalitis of unknown etiology. So let's make this as easy as we can when we're looking at images to identify these abnormalities and review these findings. I recommend you look at all available planes, and place the images in a conventional view, where if you are looking at a transverse image and you reach out to shake that patient's hand, their right hand is going to intercept with yours as though you were facing them. So the right side of the patient's body is on the left side of the screen. When looking at a brain study, I first typically compare transverse images of T2 TSE, FLAIR, fat suppressed images of available T1 and T1 post contrast imaging. I then go through the rest of the imaging in multiple planes, but that is how I start. With vertebral column, I typically start by comparing sagittal, T2, STIR, T1, and T1 with contrast, followed by transverse imaging in planes available, which is usually T2, T1, and T1 with contrast if contrast was warranted. I considered the neuroanatomic localization and whether or not that fits with the lesion and whether or not there is an abnormal signal. Why is it so important to consider conventional displays of imaging? The reason is so that we don't make errors, we don't make mistakes, and so that we do things consistently every single time. If you are in a program such as Osirix or Horos, you will see kind of markers up at the top of your screen that allow you to change basic markers on and off the image, which will show left or right on the image so that you can display them appropriately, and you can flip it if you need to. Makes it easier to communicate between clinicians if everybody looks at the images the same way, and results in less error. And this is the case I always think of when I think about why is conventional orientation so important. This is a dog that presented to a clinic for seizures and had in a post-ictal state a dull mentation and some deficits consistent with forebrain disease, who had an MRI and was found to have an extraaxial mass lesion. You'll note here that the lesion is on the right, but these images are not displayed in conventional orientation. So here, this image on the right, we actually are in conventional orientation, and we've got that right-sided extraaxial lesion. The institution where these images were created regularly displayed images, what I would consider backwards or unconventionally. And unfortunately, the surgeon that took this case to surgery did not realize that, was not conscious of that. And so when the images were displayed in the OR, they were displayed backwards. And so this patient actually had a craniotomy, and the frontal region was approached on the left, resulting in inability to resect the tumor that was on the right in this patient. When that was discovered, they did go back to surgery and correct the error, but obviously this is a pretty big one to make, and others have been known to have this occur in particularly in back surgeries and hemilaminectomies with an error on the wrong side. Want to make sure you're not doing anything to contribute to that error by incorrectly displaying images or not being aware of how your images are displayed. So moving on to image review, what are the different sequences for? It's really important to keep this in mind as you go through and try to recognize the abnormalities. You should be able to, at a glance, start to recognize the differences between the image sequences without always having the numbers up for TR or TE, or always having them labeled. And one of the best ways to do this is look at the actual muscle signal you see in each image so that you can recognize the difference between a T2 TSE seen here in image 1, a proton density scan seen here in image 2, flare image seen in 3, a post-contrast T1 seen here in 4, and a GRE image seen here in 5. This becomes, in my opinion, very helpful when you're looking at images at a glance. If you're not trying to decide what image sequence you're looking at or how tissue should appear on it, so that you know when you see periventricular hyperintensity here, that you're looking at a flare and that that's T2 weighting and it's hyperintense. And so, of course, we're not going to see it on the T1 post-contrast because it's consistent with edema. T2 weighted images, fat and fluid are bright, and they're very helpful for assessing the shape of a lesion. Look for changes in the gray and the white matter and determine whether or not the two tissues are distinct. T1 weighted imaging, I think, is most helpful for distinguishing bone structures or muscular structures. And there are differences in hyperintensity here, with obviously fat being the brightest and fluid being very dark. Pre-contrast, there are several materials that can be hyperintense. Fat is probably the easiest example, but there are several others, including cerumen, which I see more and more of as I look at French bulldogs and their ears all the time. Post-contrast hyperintensities are areas where we have increased blood flow. We will see changes in volume and, again, bony changes, as I alluded to. Proton density is an image sequence I've not seen as much lately, but it may be possible on your magnet to run transverse proton density sequences at the same time as your T2 TSE weighted sequences. These are more helpful for bone muscle margins than typical T2 weighted imaging. And I think that the distinction can be seen here pretty well. This is an example of the differences between proton density flare and T2 TSE images, which you could determine by looking at the TE and the TR for each of these. But I think it's even more helpful to look at the muscle belly, which is dark on flare and T2 TSE and remains bright on the proton density, despite the fact these are all T2 weighted images. T2 star or GRE imaging, obviously we are looking for hemorrhage, we are looking for signal voids, which in addition to being caused by hemorrhage could be caused by metal or air tissue interfaces. Stir imaging is fantastic for looking at lesions with high T2 signal as it removes the fat signal from the image. Keep in mind, you cannot use these with contrast. And fat saturated images are another way to suppress fat signal, but can be used with contrast because of the way the algorithm is utilized to create the image. Flare sequences, as alluded to earlier, fantastic for lesions around fluid-filled structures such as ventricles. So just to put those images up again that we had up in the beginning, make sure that it is relatively easy and almost thoughtless for you to decide what an image is as you look at it, but use it to compare to the other images as far as signal intensity of what you're seeing to determine what is most likely causing that lesion. All right. So for image review, again, make it easy. Do it the same every time. And I recommend when you see a lesion that you tick off this list every single time you see one. Where is that lesion located? What are its margins? Are they distinct? Are they indistinct? What is the shape of the lesion? How many of them are there? And what are its signal characteristics and the different weightings of sequences? Does the lesion contrast enhance? Does it cause a mass effect to surrounding tissues? Once you've asked yourself all of those questions and kind of ticked off those boxes, before you walk away from that study, remember to look at the tissues outside the nervous system and determine whether there are also abnormalities there that either potentially relate to the underlying cause of what you're seeing or are unrelated. The possible locations we should be writing down in our interpretation for the brain, obviously intra or extraaxial, intraventricular. We're dealing with the spinal cord, intramedullary, intradural, extramedullary, or extradural. And then that's the list of signal characteristics I focus upon. As with real estate, location is one of the most important things to consider when you are looking at an MRI because it greatly affects the differential list. So being very comfortable with the fact that if it's extra axial, you may see changes in the adjacent bone, broad contact with the meninges or the skull, an obtuse angle between the brain and the mass or lesion, and a dural tail, as opposed to intraaxial lesions where the brain is enlarged by the mass, the calvarium is typically unchanged or normal. And if the mass reaches the brain surface, there's a relatively narrow angle between the brain and the mass. When looking at the vertebral column, I think that there's nothing more helpful than examples of how this looks on myelogram. You can apply a lot of those rules directly to MRI. With extradural lesions, such as those depicted in the image on the left, you will see a narrowed subarachnoid space where that space collapses down, a normal spinal cord which is being compressed, and you may or may not have involvement of bone or soft tissue, just like with extraaxial lesions of the brain. With intradural lesions, you will see an expansion of the subarachnoid space, as it is the area that the lesion is occupying, and the spinal cord will be compressed. And with intramedullary lesions, we tend to see enlargement of the spinal cord significantly and a narrowing of the subarachnoid space. Again, at the end of your image review, did you look at non-neurologic tissues, lymph nodes, bones, adrenal glands, muscle, just to name a few? And ask yourself, was the area imaged previously? And is there anything I need to review, such as radiographs or ultrasound? And I brought one of these cases up earlier when talking about satisfaction of search error, but I will bring up another case here as well. So in the image on the left, we have a transverse T2 weighted image of the cervical region, a cranial cervical region, and you'll note we have a structure on one side that is not present on the other side. Initially, when this was reviewed by the person who did this images, there was some concern that this structure was an abnormal structure. Upon having a further discussion with the client, it turns out that this patient had had the salivary gland on the right side removed previously, and this was not actually a problem for this patient. The image on the right is one you've seen before, where we had a mild kind of chronic extradural T2 hypointense lesion compressing the spinal cord, but there were hints or indications of another lesion down here in a retroperitoneal area, which did turn out to be an adrenal tumor, an adrenal mass adjacent to the right kidney. When you are trying to decide on the underlying etiology of the lesion in your conclusions, think about the elements you know prior to imaging. When did this occur? How fast did it occur? Did it progress? What is the signalment of this patient? And do they have other clinical signs? What's the likelihood of the disease that you think this patient may have? Is it something that matches the neuroanatomical localization? Is it commonly occurring in that region? And does it fit with the history exam and your other clinical findings? Ultimately, try to put everything together to make it satisfying when coming up with your interpretation or description of your imaging findings, and then your conclusion or your presumptive diagnosis based on the imaging. Keep in mind the signalment of the patient, the history, the non-neurological features that are present, as well as the disease prevalence. know the neuroanatomical localization well. Most neurologists are very comfortable with this, other specialists to varying degrees. But ultimately, if you're confident in your neuroanatomical localization, the problem you find on MRI should fit it. What is your clinical question going into the MRI? Is it, why is this dog not walking? Or why does this animal have a fever? And try to answer that clinical question with your imaging findings. Review available images inside the nervous system and out. Describe the imaging findings, not the diagnosis. And then in conclusion, form the differential list for your findings. And with that, I think we're at 40 minutes. So I am here for questions. Question here is, how does she do that? I don't know. That is my daughter in her acro class, and I don't know how she does that.
Thank you very much. That was excellent. A really eloquent description of how to interpret MRIs in a very logical and thorough manner, and good emphasis on the use of clinical reasoning as well, making sure that we don't just use MRI in isolation, and we look towards that M for MRI being magic. So unfortunately not most of the time, but we do have some questions for you
Okay.
if you have a few minutes.
Yeah.
So first off, could you walk us through a sort of brief systematic approach of what happens when you first open an MRI study? Sort of what are your go-to sequences? What's your mental checklist for making sure that you've looked at them all? You've told us about the what you do to determine what you think about the lesion, but what do you do when you first open up that study?
Sure. So I think it depends for me on whether it's a brain or a spine. If it's a brain, the first thing I'm doing when I sit down clinically at the computer prior to interpretation is I'm pulling up the T2 sagittal image to make sure there's no signs of increased intracranial pressure before I just keep, lackadaisically looking at the rest of the study. But once I sit down to actually look at images and interpret, I typically put my view up in a 4-window view with T2 TSE transverse up top left, T2 flare top right, and then T1 pre and post contrast down on the bottom left and right. And I go through all of those images together. Once I've gone through those, that's when I usually look at GRE and DWI ADC, again with that T2 TSE up in the left window again. And then after that, if I've identified a lesion, I will use what the lesion looks like on transverse in reference to the other planes to see if I can identify it in the other planes. Going through that list, I believe here as I do it, when I'm walking through what the lesion looks like. When I look at spine, it's a bit different for me. I look at the sagittal images first, and I typically look at T2, TSE, and STIR at the same time to determine whether or not I'm seeing any lesions and whether they remain bright or suppress on the STIR. And then if I do see problems, I look at the T2 transverse and then T1 in relation or reference to those sagittal imaging with final confirmation on dorsal imaging planes if I'm using them, depending on what disease I'm dealing with. And then last thing I do, I make myself do before I get up is I found the problem or I haven't found the problem. Do I look outside the spinal cord, outside the brain, outside the vertebra, the skull to find other things, which are probably important, even though they're not quite as fun to look at as some of the nervous system structures.
Yeah, the extraneural structures are our
Yeah.
least favorite, I suppose.
Yeah.
And so you make good point of that with the satisfaction of search, which I think, well, I'll speak personally, I definitely have been guilty of. Finding a lesion seems to fit the clinical signs and everything we've thought about with respect to differential diagnosis. Is there something that you do to try to avoid that satisfaction of search, just stopping right there when it does fit all of the criteria, or is it just a case of must continue to look, make sure you're thorough at on every image set?
Yeah. So I guess when I started doing this as a resident, the way that I kept myself from forgetting was actually going back to this list. I had this list written down next to me. And if I'd forgotten to bring it, I would write it down on the top of the paper that I was taking notes on. Quite honestly, Now it's not actually something I usually have to think about. I usually just do it. But once I've found something, I try to ignore whatever it is I've found and look everywhere else to make sure there's nobody else there that I should be concerned about.
Yeah, excellent. Yeah, and unfortunately, still I have to teach myself to keep looking, even when you've found some glorious lesion that explains everything.
Yeah. Yeah.
Um, you'd mentioned quite a bit about proton density images, and obviously we don't use them a lot anymore. Have you got any tips for what they may be most suited for, or when you would use them, or do you just incorporate them all the time?
Yeah, so it depends on the institution I've worked at. Some of the institutions have just automatically had it run at the same time as the T2 TSE, which I think is the most helpful way to do it, quite honestly. Anytime you can get something for free, an MRI, time-wise, it's very helpful. But I've found it to be the most help when looking at lesions like dogs with caudal cervical myelopathy, spondylomyelopathy, where we want to see osseous lesions and osseous changes. I found it to be very helpful, and dogs with lumbosacral disease are probably the two I use it the most on and looking at images.
Great. Yeah. We have a question from Fernando who says, "Do you routinely use spectroscopy in MRI?"
In my current institution, I do not routinely use spectroscopy and MRI. One of the previous institutions I worked at had a 3 Tesla magnet, and it was something we were starting to look at, particularly in the brain, for distinctions between neoplasias and inflammatory disease, but not something we do at my current institution. It's a great question.
Yeah. Regarding the cats that you showed from that paper, with
Mhm.
a variety of vermis positions, is there a way to
Yeah.
check whether this is a normal variant, or or something that's more concerning for a pathological herniation?
It's a great question. I think the first question would be what's the signalement? Although there was a pretty high prevalence of categories 2 and 3 in this study, the brachycephalic cats were far more likely to be in category C3. But I think the other question I would be asking is, is there anything else that's causing there to be evidence of, increased intracranial pressure? Do we have abnormal T2 weighted signals in other tissues that indicate that there's swelling or edema or inflammation or something that's caused there to be a mass effect and shift structures caudally? Usually if you've got a cerebellum that's trying to leave the building like Elvis, right? There's someone that's made him do so, and someone squishing him or pushing on him or destroying him that's made it happen. So if you don't see any of those things and you are looking at a cat, I would be suspicious it's going to be one of these normals, especially when you look at the fact that very few of these cats had what some of us might traditionally think of as a normal cerebellar vermis shape.
Yeah, yeah, and I think this is then a good follow-on question. It's kind of similar theme is when you encounter an incidental finding such as Chiari malformation, how do you tease out its role in the clinical presentation, if that's even possible to answer? It's probably patient by patient, really. But have you got any tips for essentially saying that that's a lesion that I would expect in this breed or at this age, and I should move on and look for something else?
Yeah, I mean, I think the first question always is, does it fit the clinical signs that I'm seeing? And if it doesn't, quite frankly, it's very hard for me to place a lot of weight on it. The second question would be, what's the signalment of the patient? It's Cavalier, it's a Brussels, it's Chihuahua, and the back of the skull will be too round. The back of the cerebellum will look flat to varying degrees. And if it's there for, lateralizing forebrain signs, it's probably not, why we're there today. So I do agree with the thought that's probably somewhat case dependent, but I would say go back to that clinical question of, does it fit your neuroanatomical localization, and does it answer the question that you've brought to MRI to ask the clinical question?
Yeah, excellent. All right. Well, thank you again for your talk and summary of how to approach. It's an often difficult to find topic to get reviews on, and it's essential, obviously, for us to succeed in our diagnostic quest. So, thanks very much to that for that.
Thank you.
Thanks also to Hallmark Veterinary Imaging for sponsoring the first of these 4 sessions. Thank you all for attending. We will be back on October the 29th at the same time, when Dr. Elizabeth Goody will be talking about anesthesia of the brachycephalic patient for MRI, hopefully giving us all the answers we need to know for our favorite friends, the French bulldogs. So until then, thank you very much.
Thank you.